Hello, everyone. I'm Larry McNeely, Policy Director here at the Primary Care Collaborative, a national organization that convenes stakeholders from across the healthcare landscape that are committed to improving the nation's health by strengthening primary care. I'm thrilled to welcome you today to a discussion on cost sharing in primary care. We have a fantastic lineup of speakers for you today, but before we jump in, just a few housekeeping items. Like all PCC webinars, this webinar is being recorded and will be posted on our website, thepcc.org, within 48 business hours. You will also be able to find all of PCC's previous webinars on our website. We'll be taking questions today after our initial conversation using Zoom's Q&A tool, which is usually found at the bottom of your screen. Panelists will answer questions at the end of the webinar, but please do feel free to send questions throughout the entire conversation. Chat has been disabled for viewers, but our team will be providing links to relevant resources throughout the webinar. Also, the PCC is committed to delivering high-quality webinars, exploring important topics to the primary care community. We'd appreciate it if you took a minute or two after the webinar to fill out our post-webinar survey so that we can ensure we're meeting that standard. Now, I'd like to welcome today's moderator, Dr. Raymond Tsai from Purchasers Business Group on Health. Dr. Tsai is a Vice President of Advanced Primary Care, leading the PBGH's strategic initiative to implement advanced primary care in markets across the country, ensuring PBGH members and their employees have access to high-quality, cost-effective primary care. Raymond, thank you so much for joining and for moderating today's conversation.
Well, thank you so much, Larry. And I am very thrilled to be here for this important conversation. So thank you so much for PCC for hosting this and having me. Now, today's conversation on cost sharing comes at an incredibly important time. There's a new poll from Gallup actually just released last week that found that less than half of all Americans can consistently afford healthcare that they need. Now, that's a huge problem for us as in this country. So even as costs continue to rise, our nation isn't even getting healthier for it. And so it's becoming also an issue of poor value for both patients, but this is also affecting clinicians. I'm a family medicine clinician as well. And I can tell you that a lot of my colleagues are getting burned out overall. I mean, clinician burnout is at an all-time high. There's tons of red tape and countless billing requirements that just continue to pile up administratively and really impact the quality of care that clinicians can actually give their patients. It also chews into the time that clinicians have to spend with their patients, and you can't give good quality care in 5 or 10 minutes. That's not the type of relationship that really drives better health behavior. So ultimately, a lot of clinicians end up dealing with this moral hazard and decide to leave medicine altogether as they just get fed up with the system that puts too much focus on paperwork instead of actual patient care and instead of actual health outcomes. This entire system is also undermining the shift towards value-based models. Practices are really struggling to implement the different cost-sharing requirements, especially in innovative new programs, such as Medicare's very encouraging advanced primary care management codes. But this overall kind of morass of the system is really why today's conversation is so important. Policymakers and industry leaders need to understand how cost sharing in primary care is ultimately undermining the important work of building a healthier country through primary care. This is something that employers have known for a while now, which is why in my work at Purchaser Business Group on Health, we have as our number one strategic initiative to really what I like to call save primary care. Purchasers and employers have long been advocating for investment into primary care because they know a good foundation of primary care is really what's going to drive a healthier and happier workforce. So, besides the employer voice, though, I think it's really important to hear from other voices. So, I'm really, really thrilled to be welcoming three very powerful and unique voices representing the patient, the consumer, and the clinician as well. And so, I invite them to turn on their cameras as I introduce them. And so, first is Dr. Linda Delo, who owns and operates Delo Medical Associates, an independent family practice for over 37 years, and is now working for Conviva doing senior primary care. She's a past president of the Florida Society of the American College of Osteopathic Family Physicians and was a previous Florida Osteopathic Medical Association president who was honored to receive the Physician of the Year award in 2021 from that organization. So welcome. Also, Dr. Janae Johnson is a National Senior Policy Analyst at the American Heart Association, and as a member of the Policy Research and Translation team within AHA's Advocacy Department, she plays a pivotal role in advancing policies at the federal and state level that promote population health, with a particular focus on the more than 100 million Americans with cardiovascular disease. We also have Sophia Tripoli, who serves as Senior Director of Health Policy at Families USA. She is a strategic and innovative health policy thought leader who oversees and leads Families USA's strategic development and framework on all aspects of its health policy priorities, including guidance on federal and state health policy that will improve healthcare and health for all families and individuals in America. So thank you so much, everyone, for joining. Now, I think it's important we ground today's conversation a little bit. I think we can all agree that conversations about health policy need to stay centered on one thing: better health for each of us and our communities. And so, Janae, I want to start with you. We know that cardiovascular disease is the leading cause of death in the US, but our choices and our lifestyles could prevent much of that. So my question is, how does relationship with primary care actually matter to our heart health? And how does cost sharing actually impact that relationship in getting that care?
Well, first, good afternoon, everyone. Super excited to be here, and thank you so much for the question, Raymond. As you mentioned, we know that cardiovascular disease remains the leading cause of death in the United States and actually has been for more than a century. But what we also know is that a large share of that burden is preventable, and that many of the major risk factors that drive heart disease and stroke, things like high blood pressure, high cholesterol, obesity, diabetes, these things can either be prevented, detected early, or effectively managed. And that really underscores why primary care matters so much, because all of those preventive actions happen and are supported through a relationship with primary care. It's where we can identify and manage hypertension before it causes serious complications. It's where prediabetes can be identified before it progresses. People can receive counseling on nutrition and physical activity and smoking cessation. It can also be connected to specialists and community resources if they need additional support. And importantly, heart disease doesn't happen overnight. It happens over time. And so primary care isn't about, a one-time interaction because prevention is cumulative and happens through regular touch points. And so maintaining and improving heart health requires those small but consistent interactions that help people stay healthy and address problems before they become serious. And I think framing primary care as a relationship is really key to the conversation because trust in the clinical setting matters for patients. Continuity matters for patients. And there's tremendous value in having a primary care clinician who knows your history, understands your health challenges and your goals, and can work with you on that over time. And those relationships also make people more comfortable discussing issues that may not always show up in a chart, but are still relevant to heart health, like stress or caregiving responsibilities or difficulty adhering to medications. And so overall, it's where patients can get that kind of ongoing support that can make heart healthy behavior stick. And so, in many ways, primary care is really the foundation of our healthcare system and represents a really important partnership that helps people maintain their heart health over the course of their lives. Now, all of that said, building and maintaining those relationships requires people to actually be able to access care. And that's where cost sharing becomes so important because we know that even nominal cost sharing, we're talking $1, $5, let alone, more than that, that cost can be prohibitive and discourage people from seeking care. And the evidence is very clear on this that when people are facing higher costs, they're more likely to delay those appointments, skip those follow-up visits, or not fill prescriptions. And some individuals are never able to establish that relationship with the primary care provider in the first place. place. And from the patient's perspective, these decisions are coming from a very rational place of competing priorities. The cost of living continues to go up, and families are balancing rent and groceries and childcare and transportation. But unfortunately, not being able to access affordable care doesn't eliminate that need for care. It often just postpones it until those problems become more serious or more difficult to treat or more expensive. And for heart disease, that can have profound consequences. For example, an individual who misses routine care may have uncontrolled blood pressure for years without knowing it. Or a patient may be able to get that initial screening for diabetes or elevated cholesterol, perhaps because that first visit was covered without cost sharing, but then they face costs for follow-up visits or lab work or medications. And so we're able to identify the risk, but we don't fully manage it. And eventually, those untreated risk factors might ultimately manifest as a heart attack or a stroke or some other serious event that might have been prevented through timely and affordable primary care. And that's a missed opportunity from a public health perspective. And even at the systems level, when people are delaying and avoiding primary care because of cost, we see more emergency visits and more hospitalizations and more expensive interventions down the line. And then it's also important to recognize that the impact of cost sharing isn't experienced equally. Families with lower incomes and people who are managing multiple chronic conditions and many other historically marginalized communities are often the most sensitive to out-of-pocket costs, while also shouldering a disproportionate burden of heart disease. And so, these financial barriers can also widen existing disparities that we see in heart health outcomes. And so, just to sum it up, I think the main takeaway is, if we're serious about reducing the burden of chronic disease, including heart disease, we have to make it easier for people to build and maintain relationships with primary care. And that means really thinking carefully about how cost sharing policies are designed and applied. And I'll also note that the American Heart Association released a presidential advisory in April, where we articulated a set of principles for addressing affordability. And among those principles is the idea that high value, cost effective care should be accessible with minimal or no cost sharing, and that people should be able to access clinically appropriate care without experiencing financial hardship. Because at the end of the day, nobody should have to choose between protecting their health or their heart health specifically and protecting their household finances. And so, I think the more that we can do to remove those cost barriers to primary care and care broadly, I think the closer that we can move towards a healthier future for everyone.
Yeah, thank you so much for that. And thank you for making it so clear as well about how primary care really impacts other conditions in other parts of the healthcare system as a really important foundation to someone's health and how those relationships really matter to be able to get there. Um, and so this is something that cost sharing really does impact on. I will say from the employer side, from benefits design, to eliminating cost share is one of the key drivers in how to increase utilization for services. And where do we want to increase that utilization is in primary care. And so it really does have an impact. And to your point, that impact doesn't really show to all different subpopulations equally. So thank you. Now, I'm going to move over to you, Linda. So, at a time when underinvestment and burdens are shuttering like many hometown primary care practices, could you, from your perspective, give us a sense of what building that relationship means for your team and your patients' lives? And why does cost sharing hamper your ability to build that relationship?
Well, I like to just expound on what Janae was already saying. It costs money to run a practice, right? And when patients end up not showing up because they couldn't afford the copay or couldn't get the test done, that hurts both my business. I didn't see the patient, they had to go home or they didn't make it to their appointment. So I have an empty space where I could have seen someone that I can't see now. So it's a huge impact on the care. And my other concern with what Janae brought up is, we also have like a two-tiered system because our patients that are well insured and have a secondary insurance or don't have cost sharing, they're able to keep those appointments. But maybe the patients that really need it the most, that have those hardships and aren't getting the care they need, aren't making those appointments. So they're missing out. And we have a two-tiered system for those that have cost sharing and those that don't, which really defeats the whole purpose and is leaving the people that need it the most still needing. But the burden too of making sure the patient knows before they get there what their cost share is going to be, so they can be prepared. And then my time and their time is not wasted because, as we know, there's a shortage of physicians and access as it is. And then this is just compounding that issue even further. So it is a team approach as far as making sure patients know what their cost share is going to be, making sure that they have that access, and so that arrangements can be made. And the other difficult part for the team is the prior authorizations. Sometimes those are not done in advance. So they might have been scheduled for an echocardiogram. We're talking about cardiology and heart health. There may be a large copay for that, or the prior authorization for the visit was not obtained in a timely manner. So again, there's a patient slot there that gets unused when there's already a need for time for these patients to be cared for. So it does require a team approach. And there are so many different facets that do affect the success of being able to provide the primary care these patients need. And as Janae said, that corroboration and that follow-up, our most sickest patients are the ones we need to see more often. I just had a patient this week who was saying, well, do I really need to see you in a month? And I'm like, well, yeah, we're trying to follow your congestive heart failure, and we need to make sure that you don't end up in the hospital. And well, I have to pay a copay every time, and this is the exact example of what we're talking about and the concerns with cost sharing.
Yeah, thank you so much for that perspective, and also from a kind of like a more private practice perspective as well. And so and one of the things I think people forget is a lot of these things like cost sharing, right? It's easy to put on paper, but there's actually a lot of downstream effects from that, like even from a medical staff perspective, because what does that cost share actually ultimately also mean for front desk staff? It actually means
Exactly.
that they have to have systems in place to be able to collect that money. They have to have systems in place to be sure that they are accounting for all that, all those funds. It also can erode trust ultimately when you're in this situation where it's almost a transactional type relationship, and let alone for those families that are having difficulty or struggling more to pay for something, that could create a very contentious relationship that goes against what we need in primary care to really build that relationship for better health. And so thank you so much, Linda, for sharing. Now I'm going to move over to you, Sophia. At Families USA, you've issued a report after report, and I read a lot of them, so thank you for your organization for doing them, documenting consumer access and affordability. Can you tell us what's happened to primary care access and what are the implications for affordability?
Yeah, absolutely. I think, big picture, and I will pile on to my esteemed panelists here into the message and to the points that they're hitting, which is, as folks know, like big picture, right now in the healthcare system, more people than ever can't afford their care. We're seeing premiums increase. We're seeing cost sharing requirements and burdens increase. We're seeing more high deductible health plans. The burden of unaffordable healthcare is increasingly shifted onto the backs of patients and consumers, which we know is probably the biggest barrier to people being able to access care they need, whether it's primary care, whether it's specialty care, any type of healthcare. As both Dr. Dilo and Janae mentioned, like with any small, even marginal increase in cost sharing or out-of-pocket costs to the consumers and patients in this economy, in this environment, means the difference between them going to do the follow-up, getting their prescription drugs, showing up in the appointment, right? And so I think it is incredibly important to continue to highlight, especially in this moment. We know that healthcare affordability is the number one issue for people across the country right now. People are feeling the brunt of unaffordable healthcare, cost sharing, high deductibles, high premium health plans in a very, very real way right now. We expect those trends to continue. And I think what's important to point out, not only is this a massive barrier to access to primary care and a major sort of deterrent for people to just get the care that they need, there's also this fundamental issue about like, what does this mean for primary care and access to primary care in particular? And I think this is all compounds on the fact that in our country, like so many in our healthcare system, so many things are not working the way we want, right? Even if you get through the door, and you can actually you don't have the cost sharing requirements, and you can actually see your provider. So many times, folks have these experiences, these challenges navigating the complexity of the system, right? As we know, all these non-medical factors are actually driving our health outcomes, and yet the very specialists in the system, primary care doctors who are trained and know how to manage those chronic diseases, know how to get in their door, who are the entry point into the healthcare system, have long been undervalued and frankly underpaid in the healthcare system, both in terms of our actual reimbursement system, but also in terms of their overall value and just the minimum dollars that we spend as a country on primary care. It's totally inverted, right? We're spending a lot more on specialty care and on hospital care than we are on primary care, and it really should be probably inverted so that we have such a robust primary care system as the entry point, and we build up primary care practices and doctors and clinicians and workers to do what they do best, which is to receive patients, help them navigate the system, manage their diseases. But we have this moment where primary care payment is not lined up to support primary care providers in doing that. And so what that means is that, as we heard, there's when you layer in administrative burden and all the other requirements from providers, undervaluing, underpaying, we do see, first of all, we see these big systems buying up a lot of vulnerable primary care practices, right? And we see this increase in vertical integration and mega healthcare systems in the healthcare system. We also see less access, right? Burnout, primary care docs just not even wanting to get into the field at a time when we need them more than ever to really make this flip in the healthcare system. So all that to say is that cost sharing is such an important consumer facing issue at a time when we need to be reducing the burdens and the barriers for patients to being able to enter care. We also need to be talking about how we build a different payment system that better supports primary care practices, primary care providers to do what they're already doing, but just not getting paid for it. And they're burning out. And which of course cycles right back to consumers' access, patients' access to being able to get the care that they need, and to not only on the prevention side, but ultimately in this moment when we have so much chronic disease to effectively manage such high rates of chronic disease in our country, prevent those high cost hospital utilizations visits down the road, and help people actually be able to get the care that they need at a price that they can afford.
Thank you so much for tying all that together. And it's so exciting to have this conversation with all of y'all, because it's something that from our perspective, Purchaser Business Group on Health, we've seen a lot of employers that have really invested in primary care see the benefits of it. And we have one member, for instance, when we talk about chronic disease, that really invested in primary care with no cost sharing and drove utilization of primary care, and saw that their prediabetes rates from their or prevalence in their workforce went from about 50% to 24%. And that wasn't with progression to diabetes, that was actually prevention back to normal. And so primary care was able to really do what healthcare is supposed to be doing, which is preventing disease and chronic disease. And what that did for the affordability of healthcare overall, and proper management of somebody's healthcare journey through primary care, and we've had multiple employers demonstrate this, is a total cost of care savings of about 10 to 15%, or actually 10 to 20%. And so it's always really amazing to me that the rest of the healthcare system that is able to hasn't really jumped on this bandwagon of really investing, to your point, Sophia, in a way that is really sustaining primary care. And it's why a lot of employers, and like I said, one of our strategic initiatives is what I like to say is Save Primary Care, is because the employers were seeing through appointment availability and access to primary care that the primary care system was slowly dying off, and felt like if they didn't do something very different, then on its own, it would collapse on itself. So that's the employer's perspective of what would have happened if we keep going down the road we're on. But I'm curious to hear from all of y'all in terms of, what do you think if we keep going down the road we're on? What's the trajectory for all of us in terms of chronic disease and heart health, the primary care workforce, and the affordability of healthcare? And I'll let you all kind of go one by one as you'd like.
Yeah, I'm happy to kick that off, just keep our cycle going here. And I think that's such an important question. And I think the answer is that, without question, we may be looking at a future with more chronic disease, more heart disease, and unfortunately much higher costs. And the American Heart Association has actually done some work to look at what the burden of cardiovascular disease and its economic impact could look like over the next several decades. And the projections are really striking. One, we're expecting to see increases in many of the major risk factors that drive cardiovascular disease. Hypertension, diabetes, obesity are all projected to become more prevalent. And overall, millions more Americans are expected to be living with heart disease and stroke over the next several decades. And I think one of the most important points is that, certainly people are living longer, and that's part of the story. But we're also seeing these risk factors are affecting people earlier and during their prime working and caregiving years. And so we're talking about longer periods of time living with chronic disease and all of the challenges that come along with that. And again, we know that there are many communities that already are experiencing a disproportionate burden of heart disease and are likely to continue to if we don't change course. So, really embedded in this conversation about chronic disease is also a conversation about equity. And I'll also say that, we've seen projections that show, in terms of the economic cost of heart disease, that cost could approach $1.5 trillion annually by 2050, when you account for not only healthcare spending but also lost productivity. And so there's a real risk that we create this cycle where more chronic disease leads to higher costs, and higher costs create barriers to care, and those barriers are ultimately leading to even more chronic disease. And so, I think that's where we could potentially be headed, but I also think it's important to emphasize that these projections aren't just destiny, and that they can serve as, both a warning about what could happen if we simply stay on our current course, but it's also an opportunity to change that trajectory through those investments in prevention, through strong primary care and other policies that might make high value care more affordable and accessible. And so ultimately, I think that's the choice before us. We can either continue to pay more and more to treat increasingly more serious conditions, or we can invest upstream in the kinds of policies and systems that help people stay healthy in the first place. So,
Yeah, I'd like to jump in on that. I think that what PCC and our other medical organizations are doing to promote primary care is crucial, and I think that the word is out there, policy wise, and there's so many studies that show that patients that have a good relationship with a primary care physician utilize less services. They're going to come see me before they go to the ER. And but the problem is people are so used to going to a specialist for everything or going to an urgent care. And it's just it's such fragmented care that it, again, is leading us down a very wrong path. And, we really need the team-based care led by a physician, working with a team to manage these conditions and build that trust with our patients and prevent overutilization where it's not necessary. There's such a shortage of physicians across the board, not just family care, family practice, but everything, all primary care and specialty. So if the primary care can do a better job managing these things, they won't be the specialists can do what they really need to do. So many people are utilizing them when they don't need to. They could be seeing their primary care to manage their blood pressure and their diabetes and the less severe conditions, and then get a little help that then comes back to the primary care. So I think it's finally hitting home that there's a real problem here legislatively, and there's a lot being done. But I think, what this group does and other primary care organizations to move that legislation forward to help primary care be able to afford to take care of the patients, is the most important thing we can do for all of us here. Talk to our legislators and make sure they get the message of how important that relationship is for longitudinal health of our entire population.
Yeah, and I think I completely agree with everything that's been said so far. And I'll just add like a slightly a new another dimension to the conversation, which I think is just from like an overall systems trajectory, right? Like we're heading to a place where we're spending, I think, close to $5 trillion, right? Like the projections on healthcare every year, that has political consequences, right? It has political consequences in terms of if we're spending all that money on healthcare, what are we not spending money on in terms of a national budget and other important expenditures that we need to spend as a country. It also creates political vulnerabilities in terms of what are the quick shortcuts to reducing costs, cutting coverage, imposing difficult barriers on folks to make it more difficult for them to stay in covered, imposing cost sharing requirements on Medicaid, which is something that is being implemented right now because of the HR1 legislation that was enacted into law last year, right? These types of the out of control costs of our healthcare system, and not just the cost, but not having commensurate quality and health outcomes along with it it's a crisis that's been brewing for years. And I think what we're seeing now in terms of national policymaking is many of those pressure points boiling over to a crisis point. Folks will be losing coverage. People are experiencing even increasing costs, more barriers to care, the exact opposite of what consumers and patients and providers need right now to be able to get the care and that they need for themselves and for their families. So I think it's not just about, right, like there's also these political consequences of like how do we control that? And I will say I do think it's important not just all doom and gloom, but just to say like even within that there are a lot of promising innovations that are happening. There's incredible rulemaking that has happened around primary care. Last year, we're hoping for more rulemaking this year to keep making improvements on improving primary care payment. There's interesting conversations happening on the Hill, and I might be jumping the gun on some of our conversation here, but on the Hill in terms of how do we think about paying for primary care differently? What are the ways that we need to reform and strengthen some of the MACRA and physician payment reform that can drive towards a system that's actually going to align consumer and patient provider interests with health outcomes and financial security, both on the business side, but also on the consumer side. So there's a lot of
and not provide too much burden on the physician.
And reducing burden, exactly. Absolutely. Reducing burden so that doctors can do what they do best, which is take care of their patients and not have to navigate through so much paperwork complexity. So I think there's definitely a negative trajectory, but I agree with Janae that this is a moment where we can actually shift course. It's not destiny. We've got a lot of innovation, a lot of interesting conversations, particularly with primary care. It's something I think that unites a lot of folks in understanding its importance and value. But I do think it just takes a matter of education and political will and the work that PCC and many of your attendees are doing now in terms of helping to understand what this means from a patient and practice perspective is so important to keep the conversation moving. And as those political conversations are unfolding about, well, what does the future of health reform look like? How should we be paying for things? How do we reduce the complexity for consumers and for providers? Having those solutions ready-made and ready to go, which I think we have, is how we make some progress. And I think there's a lot of ways in which we're making progress already.
Yeah, you talk about some of the things they've tried to do for primary care, like the chronic care management codes. But again, the burden of trying to track the time and all those communications, it made it so burdensome that it was hard for a small practice to utilize that. And it's the smaller independent practices that are needed the most in the rural communities and the underserved communities. So, as we think about the legislative solutions here, we really have to think about that burden process because a perfect example is the chronic care management codes. I'm sorry, but there was a lot of work involved to utilize those. Now the G2211 with the add-on code is simple, and that's been a good thing. But I don't think there's still a lot of people not utilizing it that should be using it in primary care. So, that is going to take a lot of work to figure out how do we do this in such a way that is not going to create the burden, is going to provide the care to all populations and not just ones that have a secondary and don't have cost sharing, because again, the people that have the cost sharing need are the ones that probably need it the most. So, all of those things. And then there's always with legislative innovations and ideas, there's always those unintended consequences that we have to try to figure out what they're going to be and navigate those as we come up with solutions for this. And I wish I had this great solution for us because it's a very complicated and complex problem. but it's one that we really do have to come up with something, because primary care is the backbone of the health of our society. There's just no question about it. And we've got to promote it and make it work financially for patients and practices, physicians.
Thank you so much for that perspective. And it's always, as mentioned before, it's always easy to do things with the best of intentions. And then there's always what it looks like on the ground. And even still, though, thanks you for all the panelists for giving so much hope in terms of these incremental changes that have been so fantastic and shows the will of trying to improve primary care. And there will always be work to be done. And the first step is just the first of many, hopefully, even better steps towards better primary care. Now, I have one more question about cost sharing for our panelists, but before I get there, I want to invite anybody listening in to please chat in any questions that you have for our panelists that I can ask right after this one. And so the things I hear about, and so I'm hoping for some advice from y'all, is when we talk about reducing cost sharing, there's often some talk about concern for overutilization. Like if you eliminate like cost sharing, then couldn't there be overutilization? And that's something that, at least for me, I get really fired up about, because from the employer perspective, we've always kind of been on the thought of like, well, is that bad? Like kind of like what Janae had mentioned before, a lot of this is based on relationships, and these individual touch points is what builds that relationship. And ultimately, primary care is what, 5%, if not less, sometimes even less, of our primary care spends. So let's just say we waste 1% of it. It's still such a minor point in terms of our overall healthcare spend, that overall, when employers are seeing we're netting 10 to 20% of total cost of care savings, like I think it's, the math kind of works out. That being said, though, I'm curious what advice do you all have when we're being approached by these kind of concerns that, like, if we eliminate cost share, doesn't that, drive overutilization overall?
I can answer that. Patients don't really want to come see me, and I only have so many appointment slots to even put them in because I'm overworked as it is. So I don't think overutilization in medicine is an issue. People don't want to go to the doctor if they can help it. There might be a few exceptions of some lonely folks out there, but for the majority, they're coming because they need to be seen, or they know they need to be seen. So I don't think overutilization, especially in primary care, is an issue. Now, urgent care and emergency room care is way overutilized, and that may be where some cost sharing should take place, in my opinion, if it's not truly an emergency. People are going to the emergency room for a cold or a urinary tract infection, or just a torn toenail, and that's so inappropriate, and that is overutilized, I think. But the use of primary care, I just don't see that. I don't see anybody in my office ever coming in that doesn't really need to be there. And it's hard enough for me to get them to come in. But there's been lots of studies, and I'm sure you've seen in your group, that the patients that do have a good relationship and see their primary care on a regular basis do utilize emergency rooms, hospitals, etc. The overall cost savings is huge for the people that do see their primary care on a regular basis.
Yeah, and I think I'll just add, I totally agree. And I think, when we talk about overutilization, I think it's often in the context of like cost savings. Like we don't want to overutilize because we think it's a big cost driver. And I think first of all, like the biggest drivers of costs of premiums and all these things, right, are not utilization. It's drug prices, it's hospital prices, right? It's GLP-1s hitting the market, right? This is what, like, if you look into the data, that's what's driving our massive premium increases year after year. And that, of course, gets passed on to consumers and premiums and high deductible plans and cost sharing requirements, right? That's where the majority of the cost is being driven from. And I think to Dr. Yulo's point, like we do see overutilization of the hospital, the most expensive care setting in some cases. And it's really, I think, in large part an access thing, right? Like it is much easier when you're like I just sliced my finger open and I'm not sure if I need stitches or not to just walk through the emergency, the urgent care doors same day, same moment with no appointment and be seen within a few hours, sometimes longer, depending on where you are, right? Sometimes very long, versus like you got to get on the phone and you got to find somebody and they can't fit you in for 4 days from now. It's like, well, I can't wait 4 days. My finger's bleeding out. Like I'm using a very silly example, right? But I think that's why people are showing up in the emergency room, and in the urgent care centers, the more expensive care settings, but we have to just flip that, right? Like we just have to flip those financial incentives. And I think if there was better payment flowing to primary cares, if they were better valued, better paid, better reimbursed at higher rates, and that's where the like financial and the economics of this healthcare system were set up to support that as the bedrock that it is the foundational infrastructure that it is, and primary care docs had the tools and the resources, right? It would be much easier to show up at your primary care doctor same day and be like, hey, I got a thing, and go from there, right? But I think we don't have that system set up right now. That's the flip that we need to make. And I think some of the solutions that, we're talking about in terms of innovative primary care models and moving away from fee for service and addressing some of the changes to the physician fee schedule, getting a little bit more technical now, like are the types of changes we need to make that switch. And there's more work to do there, but we've made some good progress so far.
And really quickly, I think the only thing that I'll add to all of those great comments is that I really don't think the question is so much about overutilization, but more so about making sure that people are getting the right care at the right time. And we know that, so many services like blood pressure control and diabetes management and smoking cessation and cardiac rehab, all of these things are actually underutilized. And so, what are we doing to actually promote the right services at the right time while also, reimagining our system and kind of bridging those gaps that exist that do lead to some of that unnecessary duplication or avoidable hospitalizations, things like that. But what can we really be doing to promote to make sure that patients are getting the right care when they're supposed to get it?
Yeah. I'm going to start shifting to some questions we're getting from the audience, and we're talking a lot about access to primary care, and access to primary care has lots of different facets. And so one of the questions coming in is really also talking about the shortage of primary care clinicians, which we've already talked about, and that's being exacerbated by burnout. But this is also particularly in at-need communities and rural areas. And so, what do you think we can do about this as well to increase access to primary care?
Well, I'm happy to throw in, and then obviously I know you guys will add in too. I mean, unsurprisingly, I'm going to say like payment. We have to change payment. Like we need to shift the way that we fundamentally like reimburse or like primary care. I think that means like we're spending 5% as a nation on primary care. We need to set a much higher floor, probably like 15 to 20% to be on par with what other countries spend that have much more robust primary care healthcare systems. So I think a higher minimum floor of what we're spending across the board on primary care, and then a fundamental change to how we reimburse primary care so that right. It's not tied to this like, reimbursement for tests and procedures when we know that the way that primary care docs are doing and their teams is it's team-based care. They need to spend time with their patients. They need to be able to manage them over a month, a year, 6 months, right? And so we need a payment structure, upfront, prospective, global types of payments that flow to primary care docs that can give them the flexibility and the financial resources that they need upfront, so that they can do what they do best, which is take care and manage their patients.
I would just maybe add, obviously, investments in supporting and sustaining the workforce, and that means investing in training and all of those things that reduce administrative burden and burnout. And again, creating those payment models that can appropriately value primary care and those longitudinal relationships. As we think about rural communities in particular, technology can be part of the solution. Telehealth and remote patient monitoring aren't substitutes for in-person care, but they definitely can help extend the reach of clinicians and connect patients to that expertise that might otherwise be unavailable. But at the same time, there are some larger, more upstream issues that also, pose a barrier to wider implementation of that. And so that also kind of goes hand in hand with this, real need to invest more intentionally in our public health infrastructure to make sure that interventions like that are able to be implemented in an effective way.
And I would just add, as Janae was saying, the education. We spend so much for medical school education, And the students are not going into primary care now because they can't afford to pay their debt off when they can do a specialty and make 2 to 3 times the salary that a family physician might make. So this is a serious problem that is going to only be exacerbated if we don't do something about the cost of education and to equalize that, because many medical students are just not choosing primary care anymore because of the cost. I think that's a big factor there, and we're going to start seeing that. Well, we're already seeing that. Their students are going, but they're not choosing primary care to the extent they once were. So as our population ages, that's a real concern.
Now, Linda, we have a question I think that builds on something that I think you had started talking about earlier, and I'm going to let you take kind of the first answer of this. And of course, if our other panelists want to weigh in, feel free. But somebody is sharing their experience about implementing the APCM codes at their institution, and just says that one of the biggest barriers to uptake and is clinicians consenting patients is the potential cost sharing patients will have for this. And I know we're kind of on this webinar to talk about having a huge win in removing cost sharing and even for this care management program. But what's your advice on where we can start to get these conversations started?
Well, I mean, I would just say there's a problem there. I'm not sure how to go about fixing it, but I would agree, when we did have that the patients that had a secondary insurance were like, oh yeah, sign me up. And then the ones that were going to have to pay $8 or $10 a month for that APC coding, they just didn't have that money to do that. And so, we had a 2-tiered system again, which is not good. Not good. I don't really know what the solution is other than to remove that cost sharing, there. But it was a barrier, absolutely, when we implemented that in our practice.
And if I could just jump in and say, I think, and I think PCC does an amazing job of this. So I think hearing from having I think first of all, we need that removed, right? Or waived, right? And I think CMS, Center for Medicare and Medicaid Services, has the authority to make that decision. And I think hearing from consumers and patients, but also clinicians on the front line who can speak to what this looks like in practice for them and their ability to treat their patients is incredibly powerful. And so we just encourage folks who have that direct experience to find a way through PCC, through other avenues to share that experience back with regulators who can help determine and make a decision about whether that can be removed or changed or modified in any way.
Great.
And I'll say, we've got rulemaking coming up on that, in the Medicare physician fee schedule, right? It's proposal coming out next month, likely, right? So that's a comment through regulatory comment. That's a great way, even if there's not a specific proposal around it, to just drop something into a letter or drop a quick note to, a short 1-page comment that just says who you are, what your practice is, what you do, and the impact you're seeing in your practice, and to send that off to CMS as part of the public record. They do have to read them and respond to them. And so I think that's a good way, a direct way that you can have your direct experiences heard into the rulemaking process.
Great, thank you. And I mean, everybody on this call is, aware of PCC, and as kind of Sophia mentioned, PCC has been really integral in getting some of this advocacy done on behalf of primary care clinicians throughout the country. And so I think staying more in tune with what PCC is doing, as well as other professional societies or politically involved organizations that can advocate with a larger voice, or even individually submitting your thoughts to various RFIs that are being put out by the federal government about these rules, I think is also very valuable. So make yourself heard. Now, another question in the chat is talking about states having bills mandating all insurers track and demonstrate their expenditure on primary care. And in this particular example, they're talking about an average of 5 cents on the dollar to 12 cents at a dollar. And I think it's a really overall a good example of primary care friendly legislation. And so curious, the question is, are we aware of other good legislative ideas and targets in other states? And I know I'm from California, and well, I'm wondering if this person is from California, but we do have a Office of Healthcare Affordability that is tracking primary care spend over time with a goal of I think 15%, but I would have to double check that number. And and so curious what other legislation y'all might have heard about.
I'm happy to jump just quickly and just say, like, I do think there are a handful of states. I'm happy to follow up with anybody just specifically on some of what that looks like. But like California, like some other states who are setting sort of minimum primary care payment floors, we are often seeing this paired with like an Office of Healthcare Affordability or some other statewide cost control mechanism that reinvests savings back into a primary care floor, for example. And there are a couple of states that have implemented different versions of that, or in the process through, or in some variation of their legislative process, debating legislation that would do something like that. There's also, some states, like Massachusetts, for example, in the last session, I believe, where they were pushing sort of an interesting, innovative primary care payment model in their legislature that would sort of move more towards this upfront global payment for primary care type of concept. So I think there are a lot of examples, I think, of states that are trying to think creatively about this, some already with those pieces enacted, and others where they've got legislative champions and advocates in the states, stakeholders in states who are helping to think about creative ways to address this crisis at the state level.
That sounds great, because I would be willing to bet that the states that spend the most on primary care also have the best care. And I'm sure there's some research to show that.
Right. Now, we're here advocating about like reducing or eliminating cost sharing for primary care. But the reality is it's really, the reason we're here is because there is still cost sharing, right? And so what in our current state can we do if people don't have the means to pay?
Good question. I know it used to be we could have a patient sign a paper that said they had financial hardship, and we could waive the 20% of what Medicare didn't pay for, maybe their deductible. And years ago, I did that for many patients. But then that was illegal, so we had to stop doing that. You can't do that. So it's a real issue that does need to be addressed, but the deductibles even alone keep patients away from physicians many times, and certainly the copays as well. I don't know what the solution is. I mean, and private practice anymore. I mean, you can't afford to do that than what we did years ago, because there's just no margin anymore.
And I might just emphasize, I mean, obviously there's some really big problems in our health system, especially in terms of, patients and their ability to afford care and the way that our payment system is structured. And, I would just, again, kind of emphasize that one of the most important things that we can do is to kind of stop thinking about how we help them once they arrive in the healthcare system, and really, include in this conversation the need to start investing further upstream. From a heart disease perspective, we know that by the time somebody is presenting with a heart attack or a stroke or heart failure, we've already missed plenty of opportunities for prevention. And so, the question becomes, how are we helping people stay healthy in the first place? And that includes investing in that infrastructure that makes preventive care accessible, especially in historically underserved and under-resourced communities. Community health centers are a great example because they're providing comprehensive primary care and preventive services and chronic disease management on the front lines, and also are helping to address social needs as well. And importantly, they are serving populations that, again, might otherwise have limited access to care because of cost or geography or lack of insurance. And so, I just really think that it's important that we continue to invest in those upstream strategies, community health workers, nutrition, smoking cessation, and all of these policies that make it easier for people to access health beyond healthcare, because the answer isn't, to simply wait until folks get sick and requiring more intensive and expensive care. We really have to strengthen that safety net and making sure that communities have access to the resources they need.
And maybe cutting that, having Medicare or insurances pay that full price without a deductible for primary care would certainly help to drive them to primary care rather than hospitals or emergency rooms, and potentially reduce cost.
I'll just add, like in my very quickly, just in closing on this, is just to say, I think, the clinical community, like providers, you folks on the front lines delivering care to consumers and patients, have such an important, powerful voice in the discussion. And again, I'm calling out PCC for doing an amazing job with this, but finding opportunities to share your clinical experience of what this looks like, how difficult it is to navigate the system, what it means for primary care practices and the ability to treat patients, the ability to maintain, be independent in this shifting and evolving healthcare ecosystem. There are a lot of lawmakers in Congress on both sides of the aisle, in the administration, who understand, their clinicians themselves are very sympathetic and understand the very core issues that we were talking about, and are looking for solutions and are looking for ideas and, frankly, like stories that they can bring to their colleagues and build more champions. And I think that's what we need. We need more champions who are aligned on some of these key principles. We've got some good ones, but we need more. And so, to the extent that you can share your experiences as a provider and what this means, I think that's incredibly powerful. And to ultimately make this flip, right, to better investing in the services and prevention and care that we know is going to actually drive health outcomes, close disparities and equity gaps that we have in health outcomes, and give providers the tools and the resources they need to do, like, I know I keep saying this, but like, I'll just keep to do what they do best, which is care for their patients and effectively manage their chronic disease. Nobody does that better than primary care. And so I think this is just about helping to flip the narrative and the script a little bit, and how we prioritize those resources in the healthcare system.
Great. Thank you so much. And besides taking care of patients, I think primary care clinicians are also best at telling our own stories, right? And so please use your voice to on behalf of your patients to reduce and eliminate cost sharing. And to that note, there was a question earlier of what can you do? There's actually a new bill, HR 8261, Chronic Care Management Improvement Act of 2026, that was introduced in April, that would eliminate the cost sharing that many people are talking about right now. And so lend your voice to that through PCC individually or through other organizations to support this movement on behalf of patient care. And so thank you, everybody, so much for attending. And I especially want to thank our panelists for joining. Janae, Linda, and Sophia, thank you so much for lending your expertise and sharing your stories and perspectives on this important topics. And of course, thank you so much to PCC for bringing us all together and for continuing to champion on behalf of primary care for this country. So thank you so much, everyone, and have a great afternoon.